Hi, I'm Nikki Davey. I'm a quality improvement practitioner and I've had a long-standing interest in paediatric charts and systems. I'm a pharmacist by background, but I've also trained in improvement science and have an interest in human factors. I'm going to talk to you today about some problems we have with current chart design, what we can learn from other safety critical industries, and how we can apply this to healthcare. The example I'll use is these observation charts and the scoring that we use to help us identify when a child's condition is deteriorating, when they're becoming more unwell and we need to get them help. I'm going to use a PEWS chart, which stands for Paediatric Early Warning Score. We developed this as a template or guide with the NHS Institute for Innovation and Improvement. But I'm hoping that what you learn today you can apply to the use of your own form or chart or instruction leaflet that's being used for any staff in your hospital or service. Most of the time the nurse will take the pulse, listen to the breathing or the temperature of a child, and they'll write down the result on an observation chart such as this one. They then do a sum based on the observation to get a score, and the score gives them a guide or an alert, a warning if a child is becoming more unwell. So if everyone uses these charts, how is it that we're missing the sick child and failing to respond when they need help? I think I'd notice if my child or somebody else's child was getting unwell. And of course every nurse, doctor, assistant or anybody working on a ward would expect to do that too. So what's stopping us? In our world there's lots of other things happening. There are other children on the ward to attend to, there are medicines to give, there are phones to answer, there are charts to write results on, there are tests to order. There are also parents to care for and reassure who are worried about their child, and there's emergencies to deal with as they arise. And of course that's in the daytime. So what about the additional burden when the light goes down and it's even harder to do the things that we normally do and notice and attend to what we need to attend to? So how do people who work in other safety critical industries manage to deal with these problems? Well, there are two things that they do. First of all, they study human behaviour. They understand what happens when humans interact with their environment and their surroundings. And they accept that everyone makes unintentional lapses and mistakes. They also study how humans recognise things of importance. They understand how we translate these signs around us to tell us what to do and what next action is appropriate. And we use that knowledge to design and make things easier to do the right thing when we're working in these pressured environments. If you're not convinced, take a look at this example. Road signs, where would we be without them? Even a learner driver or a visitor from overseas can get from A to B. Legibility is crucial. Road users have limited time to read and process information, and there's lots of other things to attend to as there are in healthcare. These signs were rigorously tested during development. They use upper and lower case for maximum legibility. The size and spacing of the letters and the colours and the fonts are deliberately used to maximise contrast and the distinction, so for example between road types. And did this happen by chance? Well, no, it didn't. It was designed by these two people over 50 years ago, based on the knowledge that they had from working in the design research unit with other high reliability industries. And is it still used today? Well, yes, we see these road signs all around, both in this country and worldwide, based on this system. So why am I showing you road signs? Well, we started to look at charts in 2011, and we soon realised that legibility was a problem, and that many had not been rigorously tested in the way that high reliability industries go about doing this. If our charts have the information on that we need to spot the sick child, what we wanted to understand was how we might be failing in that task. First of all, we found a whole set of names, as you can see some of them here. And secondly, we found a whole series of charts. In some instances, hospitals had two charts, one that they looked at to start with and then a lookup chart. In another instance, we have charts which refer to another chart, and then a plan. And we even have an example here of 15 pages of guidance as to how to use the chart and the system. So as you can see, it's quite a difficult environment and quite a confusing picture. So we shouldn't be surprised to hear that people struggle with this. So we set about trying to simplify it for the user. We did things like reduce the number of parameters on the chart, the number of measures. We removed irrelevant information. We matched colour to risk and the chart to child. And how did we know how to do this? Well, actually, we looked at the industry standard for designing reliable paperwork and forms, and actually even computer screens. This work was done in 1994. We also looked to healthcare to see what we could find there, and we found this fantastic piece of work done in 2009 on adult early warning scores in Australia. In the work in Australia, the authors looked at 25 charts, and they found over 1,000 usability problems on these charts. So we found simple things like page information and layout, use of font and colour and observation as on the road signs that got in the way, but also trickier things like the amount of mental effort required to calculate the score, sometimes having to turn over pages to add up the numbers, and in some instances having to multiply numbers and then add them up to get the score, to then know what to do next. So these tasks might be easy on a perfect day, but as we've seen in healthcare, there isn't such a thing. So I'm going to give you some examples now of some of the things that we did based on that learning from those two pieces of evidence to try and improve the design of a chart. And this is just the template that we've designed. As a child grows up, their normal values change, and so the trigger points when we would call for help changed too. If we try and accommodate these changes on one chart, that's really quite difficult and challenging. So we copied an idea used in some hospitals already, which was to have 4 charts for different age groups. Because of the risk of choosing the wrong chart, we increased the text size and added an icon, so it was much easier to pick the right one. For example, when you're tired or it's dark and you're having to fumble around finding the thing you need. If new staff come on duty, we hope they know what to do. But sometimes staff have to cover from other clinical areas, or perhaps they may come in from an agency, so who's going to show them what to do? By using this example column here, they can see relatively simply what's required and hopefully can follow those instructions so that they can also identify a child who's deteriorating. If you're using a scoring system to alert you that a child's condition is deteriorating, it needs to be simple. The staff have got to use this when other things are going on all around. We know that scoring is the weak link in a system, so we needed to attend to this. In this example, the numbers that need to be added up are a single, so 1 for each of the banded colours. And the numbers in green, amber and red match to the alert card on the other side of the chart. Anchoring the number on the line as is shown in this diagram is also really helpful, because there's no debate about where the 40 mark is. If the 40 lies between the lines, then actually there may be a debate about whether it applies to the top, the middle or the bottom. So this really helps people in terms of reading the numbers precisely. We also need to make it easy for people to choose and distinguish between choices on a chart. So in this example of respiratory distress, we could have had 4 boxes. We could have had none and mild and moderate and severe. But actually making those decisions between those 4 when you're busy is difficult and quite subjective. It's much easier if we have to determine between none and mild and moderate and severe. So that reduces the load on our brain and makes it easier for us to do the right thing. We've already said that parents and carers often know their child best. If they're concerned, then other people should be concerned too. And this chart has a place for that to be recognised. But it can also be used by doctors and nurses. When the scores aren't actually triggering and saying there's a problem, we ignore our sixth sense at our peril. So that's why this is built into this form here. So these are just some of the changes that we introduced. So if you're struggling to get from A to B, here are some of my recommendations. First of all, legibility is crucial. We also need to design and rigorously test these charts before they're used. It's not just down to an individual who has an interest to make up what they say on them. We need to attend to the detail of the case and the colour and the font and the layout. What this means is that you need to build your own system towards something that is universally recognised and adapt it for your particular clinical setting so that it works for you. If you do use these tools and techniques and you end up with a better chart design that allows you to respond more effectively to children, I'd really like to hear about that as well, and my details are shown at the end. Thank you.